Hello and welcome back to the Ophthalmic Referrals series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. In this episode we'll talk about diabetic medical retinal referrals. I would encourage you to watch the first episode in this series, which covers the generic information that we should include in any ophthalmology referral. Please remember that this is how I would process a referral to the Diabetic Medical Retina Clinic, and you must of course use your own professional judgment and follow any local and national policies and guidelines that are in effect. And if you're not sure, you should seek professional advice. We do get a number of referrals which are directed to the Diabetic Medical Retina Clinic in error, so I'd just like to spend a moment talking about the types of referrals that we shouldn't be sending there. As long as the patient has diabetic eye disease, then you're probably in the right place. But that doesn't include other medical retina, so for example a retinal vein occlusion. Although a lot of other medical retina specialists are also diabetic medical retina specialists, they're often quite separate clinics. A disc hemorrhage in the context of a suspected glaucoma patient should go to the glaucoma clinic. And although a number of diabetic patients will need laser, please don't send them to the laser YAG capsulotomy clinic, because as the name suggests, that is just for capsulotomy. And finally, the diabetic eye screening program, actually you wouldn't send a referral to ophthalmology for that. You'd write to the GP because they're the ones that would arrange it. There are plenty of resources available to clinicians on the subject of diabetic medical retina and referrals, and I've just teased out a few which I think will be relevant here. The first one, although it's quite old now, is the Royal College of Ophthalmologists guidance on diabetic retinopathy. And this actually gives some really good guidance on the best management of diabetic eye disease. So this is a really good refresher, and there's a link there at the bottom. The second one is gov.uk, and this is much more current, and this is relating specifically to the Diabetic Eye Screening Programme, DESP. It is a refresher for a number of us on the various types of gradings. And remember, these do vary across the UK nations, but in England, which is the one I'm most familiar with, is the R0 to R3, M0 to M1 and so on. But this is a really good one to have a look at, and very pertinently they also highlight which of these various gradings they would refer on to secondary care. So remember, this is coming from the Diabetic Eye Screening Programme. So I think that a lot of that can be applied to the patients that we see in practice. And to summarise what they say, R3 gets referred, and that's proliferative retinopathy, and a cohort of M1, which is maculopathy, and a cohort of R2, which you could call pre-proliferative retinopathy, also get referred. If you have a look at the reference, you'll see exactly how those cohorts break down. And finally, looking at the College of Optometrists, there's guidance on examining patients with diabetes mellitus. And if you look at their urgency of referrals table, the only entry related to diabetes is proliferative diabetic retinopathy, which they suggest should be sent on an urgent priority basis with a telephone call. So you might want to find out exactly how your local unit wants to manage those. As usual, let's start off with the basics, so visual acuity and symptoms. These are core components of any ophthalmology referral. We then have some diabetes specific information. So what's the diabetes type? And remember, insulin dependent diabetic is quite an out of date description. So they're either type 1 diabetic, they're type 2, or they're type 2 managed with insulin. And that makes it much clearer. How long have they been diabetic for? How well is it controlled? If the control isn't so good at the moment, maybe a good time to get the GP involved. Any signs that you see, describe the size, describe the location, and don't forget about the iris for new vessels. And then imaging wise, a fundus photo for each eye is extremely valuable. What should we try to avoid in our diabetic medical retina referrals? Well, this isn't really unique to diabetic medical retina, but it is one that we come across quite often. So I've noticed, whatever it may be, some hemorrhages, some exudates. Please compare with your records and refer if this is a new finding. It's unlikely that the GP is going to look through the old records and be able to make that type of judgment. So if you feel as though somebody needs referral, based on the clinical findings, I would suggest that you initiate that referral. Once we've got the basics right, then we may look to upgrade our diabetic medical retinal referrals. The previous VA can be helpful if it's known, particularly if the VA is reduced at your current visit. Are they currently being screened by the Diabetic Eye Screening Programme? And if so, when was the last visit and what was the outcome? The patients usually have a reasonably good idea of this. You can now start to grade the fundus images, both in terms of the retina and the macula. Have they been under the hospital eye service previously, particularly in the context of diabetic eye disease? Personal medical history, specifically hypertension, hyperlipidemia, renal function, smoking status, because all of these things can upset the diabetic control. And just drilling down a bit more into imaging, you'll see the Diabetic Eye Screening Programme photographs are usually a disc-centred photo and a macula-centred photo, so that would be good practice here. And also OCT scans for any areas of interest, especially if there's maculopathy, then an OCT scan of the macula is extremely valuable. Thank you for watching this presentation on diabetic medical retinal referrals. Next time we'll look at the not otherwise specified clinic and neuro-ophthalmology referrals. Thank you.